It's my pleasure now to introduce Partha Majumder. Partha is a member of the organizing committee of the Human Cell Atlas. The organizing committee is the decision-making body of the Human Cell Atlas. So he's also co-chair of the Equity Working Group, co-chaired with Alex Shalek and Musa Malanga. The talk he's going to give is Precision Genomics Can Promote Health Equity. And I'm pleased to say Partha has many wonderful credits to kind of being this kind of co-chair of the Equity Group. He's the founder of the National Institute of Biomedical Genomics in West Bengal, India. He's also concurrently a professor of the Indian Statistical Institute. He has been elected fellow of all 3 science academies of India, and he was co-founding chair of the ethics committee and board of director of the International Genetic Epidemiology Society. And he's worked on the International Bioethics Committee of UNESCO. So please welcome Partha Majumder, and thank you very much for joining this session. And we hear about how precision genomics can promote health equity.
Thank you very much, Stefanie, for those kind words. I'll share my slides. So I hope my slides are visible. Title my talk as Precision Genomics Can Promote Health Equity. I'm going to essentially talk about diseases and talk about health equity, but I'm also going to emphasize how the Human Cell Atlas can actually promote health equity by informing about human disease. We all recognize that genomics provides novel insights into the causes of and susceptibility to disease and adverse reactions to drugs. About 10 years ago, Charles Rotimi and Lynn Jorde warned that genomics is a double-edged sword. If it's used carelessly, genomics may exacerbate disparity. I'm going to argue, and I'm going to appeal to you to consider this, that precision genomics can actually promote health equity, and I'm going to give you some evidence for this particular statement. One of the most dramatic impacts of genomics has been on children. And if you look at children, if you look at percent of surviving children with chronic myeloid leukemia, over a 20-year period or over a 60-year period or so, the percent of surviving children has increased many-fold. In the 1960s, the proportion of children with CML who survived was only about 4%. Today, it's over 90%. Now, this is a fantastic and dramatic increase in survival probability of children with CM leukemia, but this could not have happened without basic research on genetics. And the research that went behind this particular public health impact is because of the discovery that there was a 922 deletion, a translocation that actually leads to a genetic alteration that causes CML. And this translocation leads to a fusion protein, results in a fusion protein called BCR-ABL. And again, more basic research identified the biological pathways that are altered, and also understood the biological impact of alteration of those pathways on apoptosis and cell survival. And as a result of that understanding, molecules such as tyrosine kinase inhibitors were discovered, and they targeted the BCR-ABL fusion protein, as a result of which children who come down with CM leukemia, they actually survive quite well because of use of these tyrosine kinase inhibitors. Have these results had an impact in other countries, countries other than where this discovery was made? And the answer is that, as a matter of fact, this has impacted, but there is some bad news in the sense that many of these patients, as they are provided these tyrosine kinase inhibitors, they become unresponsive to to the TK inhibitors. Again, basic research has identified some predictors of unresponsiveness, and this came about by way of looking at expression levels of various genes in different subgroups of patients. And what was discovered is that a particular pattern, which is a set of somatic mutations that associate with unresponsiveness to tyrosine kinase therapy, was actually identified. All of these results are very interesting and very important in disease management, and this is all precision genomics. And an increase in this kind of precision from genetics to looking at the genome, looking at variations at the genome scale, has actually improved disease management. The question is, has precision genomics exacerbated disparity like Rotimi and Lynn-Jordy had predicted or warned us? The answer to that is that that warning has become false, largely, because these kinds of results are now have percolated into countries such as India. And I will show you a picture. These are all children with chronic myeloid leukemia. We are celebrating year before last the World Cancer Awareness Day, and this is in a particular hospital with which I collaborated. It's called the Saroj Gupta Cancer Center and Research Institute, and this particular cancer hospital actually implements all of those genomic findings in order to treat children. The information that children with CM leukemia can actually be treated and they can recover has percolated to the civil society as well. Mothers, parents are aware that children can survive, and these children who have leukemia are brought to the hospital. And there was so many children were brought to the hospital that the hospital eventually decided make a separate block for children, and most of the children who are in this block suffer from these kinds of cancers that are especially CM leukemia, chronic myeloid leukemia, that's treatable. So the point that I'm trying to make is that the genomic findings, the precision genomics findings, has actually percolated to countries like India, and India is what I'm familiar with, and that's the example that I'm giving, but I'm pretty sure that this is also percolated to other countries, other LMICs. I'll give one more example, which is that we now recognize that there is a lot of heterogeneity in cancer, and large B-cell lymphoma is one. And if you look at expression microarrays, you can actually delineate subgroups of patients, and these subgroups of patients, delineation of these subgroups of patients mean better disease management, and that better disease management has led to a better survival probability. The 3-year progression-free survival of different subgroups have actually increased. As a result of that, and this is all a result of precision genomics, understanding genomics, understanding disease at a more fundamental, a more precise molecular level. So one of the clearest messages that we get from genetic studies on cancer is that cancer is biologically more heterogeneous than we originally recognized. And this heterogeneity actually brings us to the Human Cell Atlas, and I'll provide a little bit more explanation of that as we come by. So this precision genomics has actually resulted in subgrouping of patients, and that subgrouping of patients means that therapy is now tailored towards subgroups of patients, and it's not provided uniformly across the board. So from uniform therapy across the board to risk stratified screening and treatment is a result of precision genomics. There is a reduction of overdiagnosis. If we didn't recognize that there were subgroups of patients, there would be overdiagnosis. There's more personalized intervention, and because of the more personalized intervention, there is saving of expenditure on therapy, because you're not providing the kind of therapy that will not act on that particular patient in terms of the genomic background of the patient. So overall, there is an overall increase in the number of years of disease-free survival. There is an overall saving of expenditure, and therefore it is impacting on personal health. It's impacting on public health as well. So overall, I think that precision genomics has improved disease management. Has societal penetration of precision genomics been significant to promote health equity? I believe it has, but much more needs to be done. That's the reason why from the pedestal of the Equity Working Group of Human Cell Atlas, we are trying to promote, we are trying to undertake various kinds of activities that will promote health equity, and I'll mention some of those. As I said, that although it has, this is what I do have evidence that it has, and I've provided some evidence to you. Much more needs to be done. The pace of penetration minimally needs to increase. The pace of penetration has been slow, and this pace of penetration can increase if there is greater access to knowledge, which means that one needs to educate people in places where it needs to penetrate. Precision genomics needs to penetrate. The access to technologies in such places must be promoted, must become easier, and also the use of technologies is expensive, and therefore there ought to be reduction in the cost of use of these technologies such that there is greater penetration of precision genomics in these places. Consortia such as the Human Cell Atlas has played a pioneering role in negotiating with large companies in order to bring down the cost of reagents, etc. And that's a wonderful thing to see happen. And I hope that many more similar negotiations happen, and these kinds of reagents become more cost effective or more reachable by scientists and clinicians in countries such as LMICs. The Human Cell Atlas is currently, I think, the pinnacle of precision genomics. It's defining human body cell by cell. And I underscore the word is it the human body, meaning is there a the human body? The human body can be in different, can have different kinds of exposures, can be in different environments, can have different ancestries. Even if we try to define cell by cell, do we have a unique reference, a unique reference cell by cell description of the human body? Likely not, although in the last 2 days we have seen a lot of information provided where there is a fair amount of stability of the data that are being generated across various continents and across various geographies. Yet we need to do more and need to really find out whether the human body, how much of diversity there is in the atlas of the human cell as we do single cell RNA sequencing. Eventually, the information will enable this kind of information defining the human body, the reference base that we are forming using the Human Cell Atlas is forming. Eventually, the information will enable even better disease management because there will be saving on cost of treatment. There will be a reduction in patient suffering. There will also be concomitant reduction in the anxiety of family members. Right now, if there is a child in the family who is suffering from childhood leukemia, obviously there is a great anxiety of the parents and of other family members, and this is completely almost completely reduced or vanished. The anxiety has vanished because of, again, because of advances in genomics and subsequent finding of molecules that can interrogate these pathways. There is overall an increased patient survival. So these health benefits need to accrue across geographies, ethnicities, and ancestries, across genders and age groups. So nobody needs to be left behind in the accrual of these health benefits. And I think understanding the human body cell by cell will actually promote these kinds of accrual of benefits, health benefits, such that there's greater amount of equity in the accrual of benefits of genomics and precision genomics. If we look at the extent of diversity across diseases, in various diseases across ancestries, what we find is that asthma has the highest amount of diversity for the number of people who are affected, and it's normalized by the number of people affected in the US. And this is from an editorial in the American Journal of Respiratory and Clinical care medicine not so long ago, and a few of the things that was emphasized in this particular editorial is that one needs to do research in a diversity of social, environmental, and genetic factors to ensure that all individuals receive the right diagnosis and treatments at the right time, and it must be conducted in a socially just manner by including people from all different walks of life, so to say. So this is what it is. Have we done enough? Are we doing? Do we need to do more? Before that, I also want to provide an evidence that that genomics and environment, even with respect to this particular disease, asthma, which is highly diverse in terms of its prevalence across geographies and ethnicities, there is evidence supporting an association between air pollution exposure and incidence of childhood asthma. But that evidence is inconsistent and may actually depend on genetic factors. So this particular observation led scientists to actually do more research, and there is now people have found genes that interact with air pollution levels in order to precipitate asthma, which essentially means that one needs to look at various geographies, and one needs to look at various exposure levels in order to even find the impact of genes. We know that we have not been doing enough in terms of diversity, in terms of increasing diversity in genetic research. Most of the samples in genome scale studies have come from Europeans. There's only about 20% representation of non-Europeans in most of the genome scale studies, although it's decreasing. And there was a commentary in Nature about 5 years ago where and this is a famous commentary that said that genomics is failing on diversity. And it's failing on diversity primarily because there ought to be much more, the variation needs to be understood. The variation in different parts of the genome needs to be understood. And if you look at the immune system genes, there is a lot of variation, and that variation impacts on responses to vaccines, responses to drugs, and so on and so forth, susceptibility to various infections. Ignoring these variations will actually result in health inequity, and therefore being inclusive in these kinds of studies in precision genomic studies such as HCA is of paramount importance. And that's something that has been recognized early on by scientists who are involved in the HCA, and therefore inclusivity is one of the core considerations in the Human Cell Atlas project. In terms of cancer biology, and I'm focusing on cancer biology because that's my area of work, the single cell RNA work is already addressing various kinds of aspects of cancer biology. It's talking about immunotherapy, it's understanding, well, the Human Cell Atlas is essentially providing us with reference data on cell of origin and developmental pathways, but there are also other kinds of work that's going on in the tumor tissue, and we ourselves are working on oral cancer to be able to understand the extent of heterogeneity in the tumors and what that heterogeneity means in terms of treatment, in terms of immunotherapy and other kinds of treatment. And we are always using the normal epithelial data in order to be able to understand how much of perturbation is there in the normal pathways in order to precipitate oral cancer. To promote equity, we need to share knowledge of concepts and technologies. And to be able to do that, we need to organize workshops in low and middle income countries, countries where there is underrepresentation. And we need to empower scientists from underserved and less endowed countries to participate in HCA and to participate as partners in research and translation. So we need to engage them as partners in research and translation. We need to provide them with access to technologies, otherwise it won't be true partnership. And therefore, we need to provide them with technologies. We need to provide them with knowledge and information to use those technologies to become true partners in research. And we need to help build capacity in those regions of the world which are underserved and less endowed. We need to enable, and because these technologies and use of these technologies are expensive, we need to enable provision of less expensive and more portable technologies and reagents preferentially to these LMICs, And in order to facilitate, in order to promote all of these, the Equity Working Group has been considering many of these aspects. For example, the Equity Working Group is actually working hard in order to organize workshops in LMICs. So overall, precision genomics is poised to provide the right care to the right individual at the right time in order to advance health equity. These various points that I've actually made are provided in a little bit more detail in this commentary that we wrote. The three of us, co-chairs of the Equity Working Group of the Human Cell Atlas, Musa Malanga, Alex Sherlock, and myself last year, and which is really an elaboration where there is an elaboration of various points that I have made in my talk. I will end my talk by saying that it is not just, it's not enough just for us, for scientists, to be able to promote equity by organizing workshops, by making technologies and other kinds of knowledge available to the underserved regions of the world, but there also has to be a legal support. And in 2018, there was actually a major conference that was held. How can law support development of genomics and precision medicine to advance health equity and reduce disparities? The proceedings of this particular conference has been published as a special issue of Ethnicity and Disease. And I do want to point out that there are many recommendations. There are many recommendations that are made in this particular conference. And I've just chosen two as exemplars to provide examples to you. One is failure to design law and policy to include and protect populations historically underrepresented in research poses a number of threats. And these threats are not just perceived threats, they are real threats. And therefore, these prevent engagement of people who actually need to be engaged, especially in the underserved and less endowed regions. And therefore, the legal profession is considering designing of laws and policies in order to be more inclusive, in order to be more protective of populations that are underrepresented but need to be represented in genomics research. The second point that I will highlight, or these are just two examples that I've chosen from a long series of legal issues and recommendations that has been made in this conference. The second is lack of access to genomic healthcare and precision medicine. Failure to include genomics in the essential benefits package. So the health benefits package, most of the places do not include access to genomics, healthcare, and precision medicine. And that, unless there is access to genomic medicine and precision healthcare, there will be lots of patients who will not be able to access these kinds of therapies and the fruits of precision medicine, and therefore inequity will build up, and community health centers will not be prepared to offer these kinds of medication that will exacerbate inequity. So overall, we think that there is one area, this is one area that will actually benefit humankind and will promote equity. And although there are many steps that are to be taken, and the Human Cell Atlas has actually early on taken the right steps and are moving in the right direction in order to be able to promote equity as a result of the fruits of research emanating from the Human Cell Atlas. The second is that there are also legal tangles and legal provisions that need to be made such that these can be equitably distributed in most regions or in many regions of the world, and therefore the Human Cell Atlas probably needs to engage with the legal profession as well in order to promote these kinds of in order to reduce these kinds of legal problems that there are, such that, again, the fruits of research of the Human Cell Atlas will become more equitably distributed throughout the world. Thank you very much for your attention.
Thank you very much for these kind of insights into the problems and solutions which we're facing. And one question has come in asking, how can we increase the appreciation of the importance of precision genomics among the national governments? Because I think you have some experience.
So again, I think it's a lot of discussion. It's a lot of engagement with policymakers in various governments. One of the major impediments is because it is quite expensive. And most of the time, for example, when I speak with the government in my country or policymakers and funders in my own country, they talk about the expenses associated with this kind of research. But again, the point is to be able to argue to them that unless you undertake these kinds of research overall, in terms of disease management, in terms of healthcare delivery, overall, over a period of time, there will be more expenditure than if that kind of over expenditure is actually invested in science over a period of time, there will be greater savings in healthcare. So it's a matter of making them understand. One needs to do a lot of engagement with policymakers, with funders, and with the government. It's not an easy task, but it needs to be done.
Thank you. Also, maybe leading to the next session is COVID has kind of made a change there. Has it actually already started to influence people and governments kind of to listen to the scientists more than before, and specifically to the challenges which we are trying to facing? So, for example, opportunities for more collaborations between epidemiologists and biomedical scientists. How can we help as a community kind of increase those?
Yes, of course. I mean, there's a lot of, it's kind of multidisciplinary. So we need to talk to various groups of people. And it's not just genomics. We need to obviously talk to policymakers. We need to talk to funders. We need to talk to epidemiologists. Of course, the whole range of disciplines need to be brought into this discourse. Otherwise, equity is not going to happen. It's not just the genome scientists, but also other people who need to engage with the genomics, with the people in genomics.
Thank you. Thank you very much. There was one comment from Gary Bada asking if bulk genomics, it's a comment, but bulk genomics has a technical challenge with diversity. So single cell may be able to solve this as it helps separate signal for discovery. Maybe you want to comment.
What does separate signal for discovery mean? I wouldn't be able to understand. I didn't understand that.
Sorry, he just put it in the chat. So
yeah, it's not clear to me.
He's asking,
it's not clear to me what it means by separate signal for discovery.
So I guess the question is how far we can push for the single cell analysis rather than bulk genomics. How soon will we be able to kind of implement this and bring this into the clinic? Maybe that's kind of a comment here.
Maybe.
I don't know exactly, but thank you very much for all your thoughts, and thank you. This was just one of the questions which came from Gary. I wasn't but thank you very much. I think we're going now over to the other session, and I mean, there will be, the equity group is very active, and there will be, I know multiple meetings are planned for the years to come, which I think 2020, 2023, there are already some in the scheduled meetings. So I think this will be a very, very active area, and we're looking forward to this. So thank you. Now over to Kerstin Meyer as the first chair of the session on COVID-19 and how HCA has